And I will share my screen there. Whoop. Okay, so good morning. So this morning I was going to tell you about why is my patients waiting so long for surgery. This is a common, certainly comment that I hear all the time from many of you, and certainly a reality. And I thought I would spend a little bit of time trying to explain, some of the reasons for that, and some of the things that are obviously within our control, and what it really means, and what are some of the numbers, because sometimes we get lost into obviously the patients who wait the longest. So this morning, whoops, if I can move these slides, I hope I can talk to you a little bit about, what is the safety of waiting for surgery? Obviously, do it. Is it safe? What are common myths that I hear, and certainly are common comments that I see all the time? What are the current wait lists at the New Brunswick Heart Center, and the reasons that we are constrained? And what are sort of future visions and solutions and things we've been working on over time? So waiting for cardiac surgery in general, is it safe? Well, it's unfortunately a reality of managed care. If you were in a system where there was unlimited resources and ability to change our capacity at will, then this would not be an issue. We obviously, as clinicians, try to balance risk all the time, and the kinds of things that we use to try to help us balance risk are really based on anatomy. So left main stenosis or severe aortic stenosis, those are anatomical features that are particularly worrisome for us as clinicians, and based on natural history of disease. Functional status of the patient is quite helpful. So somebody who does very well on a functional test we often feel is less likely to get into trouble than somebody who's quite marginal. And finally, the types of presentation, acute presentation or worrisome presentation, acute coronary syndrome being obviously the most common reasons patients present. Generally speaking, we tend to think of, the most worrisome lesions for us are aortic stenosis and the risk of sudden death. Stable coronary disease without left main is obviously less something that we worry a little bit less, and this is driven a little bit by some trials such as the ischemia trial, for example. A non-acute coronary syndrome type coronary disease that is relatively stable is something that patients can tolerate for quite some time. And unfortunately, patients who have mitral valve disease, long-standing mitral stenosis, mitral insufficiency, or atrial septal defect, used to be thought of as almost elective basis, and elective basis unfortunately meant for patients to wait exceedingly long time because everybody else would come ahead of them. And so the Canadian Cardiovascular Society has set some benchmarks over time, and the kinds of benchmarks that we follow here that we tend to see is patients that are in hospital. Our standard is to try to do their surgery 7 days of their cardiac catheterization. And out of hospital patients, we collapse the urgent and semi-urgent, generally speaking, because they're very hard to differentiate between the two. At 42 days of cath is really what we try to achieve based on CCS guidelines. But there are obviously special circumstances. Patients with left main that are discharged home, we try to do sooner, and those types of things are patients who are quite symptomatic. So out of hospital elective, there's really no clear standard, and we actually don't use that anymore. So there are patients, for example, on our list that are waiting a sternal wire removal, for example, that is exceedingly elective type intervention, but that obviously still makes it to our list. So the evidence around waiting for cardiac surgery, it's interesting how much of the evidence actually comes from Maritimes or Atlantic Canada. This, in the 1990s, you may recall Jaffna Cox published sort of a tiered approach to triaging patients for cardiac surgery based on in-house semi-urgent type basis. And this was really the premise by which in Halifax in 2000 or so, we published in Circulation. I was not part of that publication, but my colleagues were, looking at, what is the impact of waiting for cardiac surgery in about a 2000 series of patients. And basically, we're able to show that death and upgrades while patients were waiting on the list tended to occur early in the queue process, and prolonged waiting was not associated with worse surgical outcome. And that's an important point that comes out, is that it's not necessarily the patients that wait the longest that have adverse events. Is our ability to pick or to identify the ones who get into trouble often is not always perfect. And often patients who get into trouble can get into trouble early. And that's an important point to remember from this. The mortality risk on that wait list of these 2,000 patients was under 1%, so 0.7%. Another paper that I was involved with, again, coming from Halifax, is we looked at the safety of waiting with left main stenosis going home. So these were several hundred patients, and we're able to show that the outcomes of patients being done while in hospital versus out of hospital, if you adjust for differences between them, we were not able to show that obviously in appropriately selected patients did not increase mortality or morbidity in these patients. So it doesn't mean it's risk-free. It just means that from a statistical point of view, we can show that there are patients that we can manage in that manner. And then one other piece of work that we did in Halifax at the time that also sort of enlightens a little bit on the weight aspect is that while we think of benchmarks, as I've mentioned, from all of these are calculated from the time of cardiac catheterization to the time of intervention. So it misses in most patients a large part of the weight from a patient's perspective. And that from a patient's perspective is when they started having symptoms, when they saw their doctor, when their doctor sent them to their specialist, when their specialist ordered the test, and eventually got a cardiac cath. So there's actually 2/3 of their weight often is prior to the index time where we start calculating time. So that is something to remember from a patient perspective point of view, as many of these patients have waited a long time. And we're able to show in this particular manuscript that, if you presented to the emergency department and were sort of expedited with an acute type presentation, your overall wait was generally way shorter than someone who presented to their family doctor and eventually went through the system. So, which is not surprising. So how long is it too long to wait for heart surgery? Well, unfortunately, the reality is I don't know the answer. And the reason I don't know the answer is that nobody really does. If you wait long enough, you will have adverse events, and that's unfortunate, obviously. So how do we manage all of that? How do we deal with true data versus opinion? And unfortunately, there's lots of opinion out there. We live in the world of now a new coin to fake news or those types of things. Hopefully we don't have fake data. So here are some facts that I think are worth for all of you who work, or affiliated with a heart center across the province that you should know about, or at least have some idea. The first one is, despite the pandemic, we did more surgery in 2020 than we did in 2019. And that's something that's important for everybody to know and understand. I hear sometimes, oh, it's the pandemic, it slowed things down. It's affected, yes, it's affected things. But, through a lot of efforts from many, we were able to keep volume. And actually, in fact, since 2016, we've increased capacity by about 15% or so. And if you were to look, we did 926 intervention at the Heart Center in cardiac surgery last year in 2020. 117 of those were transcatheter valve. And 66 patients, we had a case deficit of 66 predicted based on cancellations around the first few weeks of the pandemic with the measures that were placed in March. So clearly we could have done more based on that. But there are other aspects of this that are important to know, is the majority of patients in that year were actually done or perform within 10 days of their cardiac catheterization. So we do a large majority of patients, 2/3 of patients are done as in hospital. That means they present, they get their cardiac catheterization, and they have their surgery within 10 days on average. Actually, 64% of them have it within 7 days. So the majority of patients we do an entire year are actually in hospital patients. So there's tremendous pressure from an acute coronary syndrome and or acute presentation point of view, or patients you're worried about from an anatomy point of view. And I'm sure all of you have seen this. So there's a tremendous throughput. It does mean that 1/3 of patients, though, that are well enough to go home end up waiting quite a long time because of that. Because, for example, on a week like this week, we almost do no outpatients. We do almost all inpatients. But it does show you that the majority of patients are done within a very short period of time. And there's tremendous pressure from that. So our focus on inpatient does mean that outpatients end up waiting longer, and the median wait time for these patients is enormous. I said 42 days is a standard we try to reach. We run between 120 and 150 days a median wait for those patients. Only 20% of these patients are done within 42 days. sorry, I'll just put my laser pointer here so I can show better here. So that's an unfortunate reality that's always very difficult for all of you to manage and for us to manage. So here's a look at our dashboard. So the dashboard has been something we've been able to implement in the last year or so through tremendous work with IHS and sort of our partnership in the past. This is a look at the dashboard for a 1.5 year period, starting in January 1st, 2020 to July 31st, 2021. During that period of time, these are the procedures that were performed. And this is what's really important for us, is the outcome indicators that are of concern. 3 patients died while waiting for surgery in that period of time. And that's obviously terrible. And so there is a risk, obviously, of waiting. 62 patients were readmitted for worsening symptom, the majority of them, or we felt that their symptoms were not manageable and tried to get them upgraded on the list. So this means a 0.2% mortality risk while waiting. And it does mean a 5% risk of worsening while waiting, or if you consider only the outpatients, it's a 14% risk for patients to have worsening symptoms requiring an upgrade of some sort, so being admitted sooner than they were on the list. If you'd refer back to the publication I'd shown from the year 2000, the mortality risk in that publication was 0.7%, and the risk of being upgraded was 25% at that time in Nova Scotia. So what limits our capacity? So our capacity is really, we're the only heart center, obviously, in the province for doing cardiac surgery. We do more than 900 surgeries, as I said, per year. We've had the same 2 operating rooms from 1991 to 2021. The capacity of these 2 operating rooms, in general circumstances, 2 cases per day per room, that means 20 cases a week, is generally what is possible. Obviously, some cases take all day sometimes. So there are, this is a general assumption. We performed last year 17.8 cases per week for 52 weeks of the year. So that means every single week. So it gives you an idea that we are pushing the limits of our capacity from these 2 operating rooms. And this, takes a tremendous amount of work from all staff at the NBHC at all levels to achieve that, and people should be very proud of that. But it also illustrates that this is often our limitation in terms of our capacity. I can do 4 patients today for sure. I'm hoping to, assuming that my ICU beds, my beds elsewhere are okay, but I am limited in that capacity. So what is the perspective of how do we compare to our neighbors? For example, in Nova Scotia, I know I've shown this slides to some of you before. It just highlights a little bit of some of the differences. Here's the New Brunswick Heart Center in this column. Here's the Maritime Heart Center in this column. I've worked in Halifax for 21 years. These are numbers are a little bit of estimate because I obviously don't know what they did exactly last year. But in New Brunswick, we did about 926 patients. They do a little bit over 1,000. There are 4 or 5 surgeons depending at the current capacity. They have 8+ surgeons. We have 4 anesthesiologists that do cardiac surgery. There are more than 9 in Nova Scotia. We have no house staff, no foreign fellow. We hover between 4 and 8 beds. Majority of the time now we're at 8 beds in our ICU. We have 4 step down and 2 operating rooms versus 3 to 4 in Nova Scotia. So clearly there is our ability to increase our capacity is limited in some parts by some of these limitations, as you can see here. So here's sort of an outlook of how things have been over the years. Here in 1991, there were 2 operating rooms that were staffed. They were not staffed fully every day. And over time, these rooms were staffed fully to the point where in 2021, they've been staffed fully to allow us to do these 2 operating rooms all the time, most of the time. And we actually stretch our staff to go into the cath lab or the interventional suite to do TIVs and TVARs and really pushing the limits in terms of cases we can do. We've been lobbying certainly for the last, since I've been here, for additional operating room and staff. So we have the physical space, but utilizing that room and the equipment and the staff for that, we do not have, because certainly adding a 3rd room for us, even a few days of the week, would tremendously help us in terms of our capacity. And that's something that we've submitted to government and Horizon and is something we've been working really hard for. So the reality of all this is, the problem will not get better magically. The demands for cardiac services in general for all of us is high in New Brunswick. I think we're facing pretty important population pressures. If you look here at 1970, the way our population curve looked like, it was like this. In 2018, that bolus of baby boomers is just starting to hit the 60s to 70 years. And then, we're in 2021 right now, that bolus is moving up. And clearly these patients have more likelihood of cardiovascular disease, potentially requiring intervention or care from us. So we're just facing this, and it's hard to imagine that this will get better, certainly in the short term. The problem is not unique to New Brunswick Heart Center. What I'm telling you about, I'm sure all of you are feeling many of these restrictions or aspects. But as the sole provider for cardiac surgery, it does affect everyone in the province and all of you and your patients that you're caring for. So in summary this morning, hopefully, the reality is wait lists are a reality of the Canadian managed care model. I think that's clear for everybody. I think ongoing efforts by all members of the care team is critical in triaging patients as best we can. I think it's important to remember that longer waiters are not necessarily the ones who face adverse events. And, we've certainly seen that during the pandemic, where many of us have spent quite a bit of time following patients quite regularly to try to identify the ones that would require intervention sooner, who'd been waiting a long time. We are at a critical junction. I think our demands exceed tremendously our capacity, and we face decisions every day of who is the most sick person I need to do right now all the time. And it is something that, that responsibility, I feel acutely, and I'm sure my colleagues feel acutely, and I'm sure most of you feel acutely all the time. These are difficult decisions. I think we all play a role in advocating for our patients ultimately. And this is where I think it's important to educate ourselves. This is why the rounds, this is why we talk about it. I think data is important. I think none of these things are perfect, and we are doing the best we can, but we need to push all the time for getting more resources and to get more ingenuity in the way we take care of patients to try to obviously provide more care. I think we need to educate elected members of government who may not understand all of these aspects. I've certainly met many times with them, bureaucrats and health authorities, to keep advocating for what we do. I think collaborations amongst all members of the Heart Center and outside all of the cardiology community within the province and communication is key so that we can do the best possible for all of our patients. I'll stop there and entertain questions. Let me stop sharing my screen and open for questions. All right, so good morning, everybody. I stopped my share there. All right. Any questions from the audience?
JF, do you think your length of stay is any different than other places? Does that contribute to our ability to do more cases?
Yeah, I don't know the answer to that in comparison. Our length of stay, we try to aim for a median of 5 days, but it hovers between 5 and 6 days after cardiac surgery. So we do push pretty hard to get patients out. We get tremendous help from our referring hospital to try to repatriate patients that take longer. So the turnover from that point of view is a bit better, that's for sure. I do feel that whenever we identify a bottleneck or we find a solution for a problem, we then unearth another bottleneck, as you know. So you increase capacity here, then you realize that, oh my God, I can't move there. So there's always a moving. So every time you feel that, when I first came here, ICU capacity seemed to be a huge issue. We spent a lot of effort trying to identify ways to fast track patients, prevent IV patients from going to ICU. There were all sorts of things that were put in place that tremendously helped our ability in the ICU, and then recruitment, new management, and sort of lots of different things that helped out. So it sort of shows you how it is. We don't have a very flexible system, as you know. Whatever we end up doing, it takes time to work at, and I've proposed a very easy solution here, an extra bed, an extra OR room, an extra ability to do things. But as you know, it's always a little more complicated than that. But certainly that would open some doors to my ability to do more, for sure.
Okay, thanks.
Yeah. I mean, what's striking to me in all of this is the tremendous change from, 5 years ago, we did about half as inpatients to a little less than half to now being 2/3 of our patients are in hospital. and that's a trend that I saw in Nova Scotia prior to this also. It is a little bit frightening in many ways that it illustrates all of our sense that, you know, when you have patients you worry about, you end up admitting them so that they're done in the hospital rather than relying on the fact, oh, they'll be done in 2 weeks or 3 weeks. So it does illustrate that fact. I mean, we all do what we think clinically is most appropriate for our patients, which is the right thing to do. But it does absolutely drive, you know, if I know there's 25 patients waiting in hospital and I have 20 slots to fill next week, it becomes really, really hard for me to fill a few outpatients in there, even if I think they should be done soon. So the pressure is tremendous from all of you and from myself. And I don't know how to best do that. We try to limit, you know, we try to have a few slots that we always keep for outpatients, that kind of stuff, to make sure that we get things going for patients that waited the longest. Another aspect that never comes out is there are patient factors that do not, you know, I chatted to a guy yesterday, you know, left main that needs to be done. He's at home. He says, there's no way I'm going to get done before second week of October because I've got all this shit to do. You know, that doesn't really get translated that well in our wait list and our wait statistics, unfortunately. So I tried yesterday to convince him otherwise, but he was adamant. I'm not, you know, I got all this stuff to do. Okay. You know, it is reality.
JF, it's Sue Morris. This is more of a comment rather than a question. From my perspective, I think the Heart Center is just starting to see the impact of the nursing shortage. I know it's been significant in other areas, and we have been a relatively easy spot to recruit. And I'm finding that's not quite so easy anymore. So I am fearful that that's going to have a significant impact on what we do in the next 5 years.
Yeah, I would agree with you. I think there's a few aspects there that I sort of feel in some ways that we need to rethink a little bit in many ways on how we do things and how we task certain aspects of care. And because if we keep doing the way we are doing with less and less potential staff, it can only get worse, and quality of their lives working in that environment is also get much harder. So I mean, I'm looking to nursing leadership and nurses in general to really, there's an opportunity here to rethink a little bit on how we do things. But I haven't seen much of that. Maybe you have a better insight in how that potentially would go. I do fear, as you suggest, that, you know, yeah, nursing shortage are going to affect all of us in many ways. Yeah.
Yeah, I do think we need to rethink the way we do our work. And I think that requires some visionaries, but I also think it requires some autonomy in decision making, and that's not always possible within Horizon.
Yeah, I would agree. I mean, I do remember a conversation, just, you know, joking around with nurses in the ICU that were telling me a third of their time was documenting. Well, I said, you know, maybe we should hire an assistant, an administrative assistant for the 3 of you at these bedside. They would be in charge of doing the documenting, and you could actually take care of 2 more patients. They were laughing at me, but, you know, these are, yeah, you know, these are the kinds of things we got to think outside the box. If you spend your entire time answering surveys and documenting things that someone could do for you and better use your expertise in caring for that patient, that's a way better use of people's expertise.
Yes, absolutely. Thank you. Great presentation.
Yeah, thank you. So this will close for this morning. So thank you very much for all of you for joining this morning. And next week, Dr. Chris White will be telling us about the modern management of massive pulmonary emboli, and obviously how from a cardiovascular community that can be the type of patients we may be involved in. So you might think that it would not be, but, you know, there are things that we can do to help and potentially provide some expertise. Thank you very much.